Thank my fellow session speakers. Full disclosure, I'm not an epidemiologist, so I appreciate Dr. Balsbury and Dr. Ogeni tolerating a neuropsychologist being on the stage in this session. So I'm from Wisconsin, so will this work? You can still hear me okay? Okay, all right. All right, so I want to talk about incident dementia in non-Hispanic African Americans and whites. And this came about from some work that we published in 2019. It's a bit old, but it's one that I think is so important to talk about. I was planning on talking about it 3 years ago when we were supposed to have the conference, so I will promise that it's worth the wait. So let me go ahead and advance the slides. First thing, our disclosures and co-authors. I just want to really thank these because it's a work of a team. In particular, I want to thank my partner in this work, Dr. Fabu Carter, who is my truth teller, and you'll see how important that is as I get through my slides here. So, and I also want to thank our participants. None of this would be possible if it weren't for people volunteering for research. So, how many here are participants in a research study? I applaud you up front. So I really appreciate our participants for taking the risk of joining studies. So learning objectives for today, I want to review what we know about engagement efforts and how it works, and then how these enrollment factors can influence our science. A lot of times we don't think about that. And then also some pitfalls that we need to think about as we make comparisons, how we do our science, considering these things like enrollment factors. So to do this, I want to cover a different range of topics, including what we're doing to address disparities, specifically inclusive research, the downside to community-based participatory research, and some concluding thoughts. So I will start with mentioning and acknowledging that there are many models of community-engaged recruitment. I have been heavily influenced by community-based participatory research models. So that is a field in and of itself. I don't pretend that I'm practicing community-based participatory research, but I am adjacent to it and, again, heavily influenced by the principles of community-engaged research. So the first thing I like to do is to acknowledge, of course, we talk about cultures, and that we acknowledge that the cultural factors influence whether or not a person participates in research. It is certainly mistrust and access are key to that. But I would like to say, too, that it goes deeper than that, in large part because there is a culture in research and academia that we don't often acknowledge, and that actually excludes people. There's systematic factors that work against including people in research. Everything from our inclusion criteria to how we treat people when they walk through the door, how welcome they feel. These are all factors that actively exclude people. So access and mistrust are part of it, but then we go back to and center this on things that we can do things about, and that's change our culture as a research institution or an organization. So as part of that, this is the model that I largely work from, and it proposes, if we have two cultures, let's build an intercultural bridge. And in order to do that, there's key things that are part of that success. On the university side, we have to be willing to share power. And to listen to advisory boards in real ways where we actually engage and enact the recommendations that they're making. We have to be comfortable with the no strings attached. So we go in and invest in a community whether or not it pays off with research and participation. We have to be comfortable with that. We have to be willing to listen and to acknowledge the lived experience of our participants when they tell us things. So again, when they give us the truth, we have to be willing to listen to it and act on it. And this is one that I think is not yet pervasive in our research culture, is that there's an expectation in community-based participatory research that when a participant or a community brings to you the problems, that you then participate and advocate for changes within those systems. That you don't just say, well, that's the university policy. What you do is you say, that's not a reasonable policy. We need to work to change that. That advocacy part of it is again, where I'm heavily influenced by the community-based participatory research models. On the community side, you need a truth teller. or truth tellers who tell you really what the problems are that are getting in the way of participation. And tell you truth, basically saying, well, where are the scientists from my community? Well, and that's actually where I like to say that I'm interested in replacing myself with people who are coming from the communities with whom I'm working with. So that's a big part of what I do, is that mentorship of individuals who are coming from the community who have the lived experience. And a willingness to look for solutions too. So these are all key elements on both sides of the bridge. Connecting those sides of the bridge are individuals who can work, who can have a foot in both worlds oftentimes, who can be that liaison between the two worlds. In my lived experience, it's my partner, Dr. Fabu Carter, and I, who I feel like are really, we're more than colleagues, we're friends, and we're really supportive of each other and actually help build that bridge. Conflict is normal when you're in those situations. A lot of times in our research culture and our academic culture, conflict is verboten. You are not allowed to have conflict. Conflict is actually a natural part of bringing together two cultures. And that when you resolve that conflict, you acknowledge that you are actually going to make changes on both sides of that bridge. So again, this is sort of the model I'm working from, this intercultural bridge, acknowledging that we have a culture, and unfortunately, a lot of times that goes with that culture is this hegemony, that this is the way you do things. It's the best way to do things, and of course, why would we want to do things differently? The more we can set that aside, the better off I think we are as a research community. So I like to then also point out to usually my bosses, well, this is a timeline. You've heard this expression that engagement works at the speed of trust. So it takes time to build trust. So oftentimes when I go into a new community, it's about this idea of like building trust, and we give first and with no strings attached. And that phase is about getting to know each other. Not buying participation, but a time to say, hey, look, here's what you need as a community. I'm going to listen to it and respond to it. Use our resources for that. It's not hard, unfortunately, with Alzheimer's disease to build advocacy because so many people have been touched by the disease. So if you find someone who says, this is important to me because my family was affected, there are your advocates. So one of the first things I like to do is to hire that person as an advisor, a liaison. And then you reach a point where there's reciprocity on both sides. So this doesn't happen overnight. So when I say, look, we're going to invest in a community, a new community I'm going to work with, I want to upfront tell the timeline to those who are looking for that sort of when are we going to see dividends? Well, I'm going to say what's going to happen at the speed of trust. So I like to recenter in that recruitment is not going out and getting people and counting the numbers, it's engagement. So we recenter this. This is a paper by a dear friend of mine, Neil Henderson, where he talks about this hidden hegemony. And I like to come back to him and say, oh, it's not so hidden, Neil. There is a real sense of centering this, defining the problem of recruitment and engagement as on the community. I like to recenter it onto the university side. What are we not doing to engage? Why are we not meeting our goals of inclusion? So this is following this model, this is what we've been able to accomplish with African Americans fighting Alzheimer's in midlife. Thank you, Joy, for mentioning the importance of 20 years earlier primary prevention. So the goal of the AAAFAME project is to address modifiable risk factors. Keep that in mind, modifiable risk factors. That's what we're going to look for. And so the AAAFAME works by investing in this engagement process, and we enroll in existing protocols and fund the science. So we support the engagement steps, we support staff who are from the community to be part of that data collection process, and we also support the scientists doing the work to look at the factors associated with midlife. So we just got renewed this year, and we've been able to we have a new set of questions that we're going to explore. So the data I'm going to show you today is actually, it's older data, but it's, like I said, important. So what we do with this engaged model is that we have to be prepared to answer that question of how does this benefit the community, and not in these vague terms of like, well, you'll be included in science, it'll help science. That's important. I acknowledge that, but we also want to be able to say how we're helping the community in real ways. We invest in Black-owned businesses, or I also work with Indigenous communities, Indigenous-owned communities. We make sure our trainees, like I said earlier, we want to make sure the trainees from those communities are supported. This is a major initiatives that we want to make sure that we bring in scientists who look like the communities we're trying to engage. So what we've been able to do in our AAAFAME study, we just this month reached 465 participants, most of whom are still in follow-up, are still engaged. So we were at about 70% still are engaged in this study. And we're collecting a wealth of biomarker data, Alzheimer's disease biomarker data, which is I was talking earlier about how fast-moving that field is. A goal for me is to make sure that African Americans and Indigenous Americans are included in that research so that they feel confident when they go to the doctor and they get the new blood test that they know that the number that they get is meaningful for them personally. A lot of times this is in most of our recruitment, we do have a site in Milwaukee, but most of our recruitment is coming out of Madison. So in Madison, Dane County, it's only 5.4% of the population self-identifies Black or African American. So this is engaged research in a hyper-white environment, as a colleague of mine calls it. A unique cohort in a way, but also like, again, I'm so humbled by our participants' willingness to take a chance with us. This is what we've done for our American Indian enrollment. We just started, we just ramped up. We got permission from the Oneida Nation to officially recruit at Oneida through their business committee. And so we just started, and we are at about 100 individuals who identify as American Indian. There's only about 200 in the ADC registry, so again, Wisconsin tribes are making a big difference there. So the renewal for our AAAFAME project, we want to test that amyloid hypothesis in Black Americans to, again, make sure that this amyloid hypothesis that is really sort of the accepted hypothesis, does it apply to African Americans? We want to make sure that these new plasma markers are aligned with the PET data that are collected. And the PET data are measuring amyloid in the brain. Let's just make sure that mechanism holds up. And then finally, a science of recruitment aim. Very much testing that model of engaged research, and my colleague Andrea Gilmore-Bukowski's model of how to transverse the cultural factors that get in the way of enrollment. So is there a downside to community-based recruitment? So something happened a couple of years ago that kind of puzzled me. We began looking at the data in Knack. So Knack is the National Alzheimer's Coordinating Center. It collects all the data from the centers around the country. About 5,000 African Americans enrolled in there in the Knack data set. And we looked at those, thank you. We looked at the data, and we found something really surprising. So here's you've heard from Dr. Ballsbury about the epidemiology of Alzheimer's disease in the US. So we looked at, these are the Kaplan-Meyer curves looking at survival without dementia. If you start out in a group, so we look at individuals who are cognitively healthy at baseline and we follow them over time, and we look at Blacks versus whites and non-Hispanic Blacks versus whites in the Knack cohort, you don't see a difference in rates of incident dementia. We're puzzled by that. If you started out with mild cognitive impairment and we followed you over time, if you were Black, you had a lower risk to progress to dementia. Topsy-turvy from everything we knew. So we were trying to understand why that would be the case. Maybe our African American participants are healthier who are enrolled in the Knack data set. Well, they do survive longer than our white participants. So just to orient you to these columns, these are stratified by cognitive status at baseline, cognitively healthy versus MCI. Those who were Black individuals live longer in our Knack cohort, but they're not necessarily healthier. They have more diabetes, they have more hypertension. The one difference that was favoring favoring blacks in this case was cardiovascular events, but there was a small number overall, only about 5 to 7%. So that hypothesis didn't hold up. They're not necessarily healthy. What else could explain it? So I began to look at things like, because I knew how the center did in recruitment. I did the recruitment for our underrepresented groups. So I know that I go to the community to recruit our African American participants and our indigenous participants. But where were our white participants coming from? Well, I looked at Referral Source, and you could either be referred by a health professional or yourself or a friend or relative, so those two categories. And I also looked at family history of dementia, whether you had a relative or not. And I would actually argue that that family history is not a genetic marker as much as it is access marker. Did you have access to diagnosis? Knowledge of family history, in other words. So these are our choices. So referral source, you could either be referred, you could check a box that you were referred by a self, friend, or your relative. So community recruitment, I suspected, versus a health professional. One of the first things you do when you establish a center in this system is you set up your clinic, and your neurology clinic usually. So a specialized clinic at an academic medical center. Guess who's going to that? A lot of wealthy, well-educated white people. And then family history, you either had a family history or not. So this is really interesting. So we look at the number of individuals in these two stratified categories who are referred. If you were a black individual versus a non-Hispanic white person, you were about half as likely to have been referred by a health professional to the ADRCs. And you were also less likely to have a family history, known family history, I'll put it that way. So our nested regression models, we first looked at our control factors and then added in those referral factors and family history. So I'm going to show you, this is I'm not going to show you this right here, but I'm going to focus in on this last section, the bottom section here, and show you these kind of surprising findings. So our reference is if you were referred by a friend or relative. If you were referred by a health professional, you were 39% more likely to develop a dementia than if you were referred by a friend in these people who are cognitively healthy at baseline. Same with family history, 22% more likely to develop a dementia. Again, I say that's known family history. So highlights from this cognitively healthy model is that if you had a higher education or if you're a woman, you had a reduced risk for progressing to dementia if you started out as cognitively healthy. Diabetes increased your risk. And compared to those who were referred by a family or friend, you were 39% more at or increased hazard, to progress to dementia. If you had a known family history, you're 22%. So being referred by a health professional put you at greater risk than your family history, interestingly. Now the mild cognitive impairment group, and we looked at this right here. Again, you were 46% more likely to progress to dementia if you were referred by a health professional. And a family history puts you at 12% increased risk. So, again, in this case, if you were black, you had a reduced risk to progress to dementia. Oh, okay, stop already? Oh, I missed the warning, sorry. So I will say this, that the cohorts differ. If you're recruited into an Alzheimer's disease center, the black participants were different than the white participants. And what does this mean? I think what happens is our clinic recruitment, which overrepresents white individuals, are cherry picking those individuals who are at highest risk. Versus those who are recruited in the community who are either at lower or perhaps even more representative of risk. So I worry, as someone who's interested in modifiable risk factors, that we are, by over-relying on the science generated by the white participants in our centers, we are missing modifiable risk factors because these individuals are healthy, well-educated, resourced, and at high risk. So I'll stop there.
Thank you very much. So we have time for a few questions before the first break. And once again, if people could just identify themselves so we know who's here joining us. Oh, I know who you are. You don't have to identify yourself.
Sholo Goldie.
Yeah.
As a neurologist, I'm interested in CSF.
Yes.
What are the challenges with obtaining CSF and especially for such community-based studies?
So the question is, what are the challenges with obtaining CSF? Absolutely, obviously, historically for Black Americans, it's in the mind always about the Tuskegee studies. Not only that I perceive it as more invasive oftentimes than a PET scan. So there's a number of challenges there. And we're asking people to do this out of the goodness of their heart, and they have to be able to oftentimes have someone drive them. There's a lot of barriers, but I'd say the biggest one is the invasiveness of it. We've moved more towards the PET imaging. It's as good, and it picks up in unique ways, maybe something even better. And plasma. Plasma is going to be a game changer. I'm so excited about the plasma biomarkers. Yes?
Hi, I'm Peyton. I'm from NYU Health and Brain Aging and Sleep Center. So we currently are running a study looking at slow sleep activity and Alzheimer's disease in African Americans. And one thing that we noticed is a lot of our participants are actually very, way higher educated.
Yeah.
And also really higher up in the socioeconomic status.
Yeah.
So I was wondering if you had access to that, because we tend to get a lot of our participants from NYU.
Yeah.
It's a private hospital.
Oh, gosh. Yeah.
It pretty much explains why our participants tend to be higher educated. But we do know that it's not really representative of the population, per se. So I was wondering if you were able to get any of that information, like any demographic information, your education, SESS, anything like that?
Yeah, thank you for that question, Peyton. She asks, she's commenting at NYU that her participants, African-American participants,
Yeah.
okay, are coming from a demographic that is highly resourced, highly educated, connected to the university, right? And this is my little soapbox moment of let's move all of our recruitment out to the community.
Yeah, most of the recruitment is community-based, but from the people that we have acquired from they're higher educated.
Yes. And when I say community, I say actually we have multiple community sites for recruitment, I would say, that we actually look across. That's a typical thing. Research volunteers in general are super people. So all you in the audience who are research volunteers, you guys are super agers probably already. So, but how do we get a broad swath? We take a more population-based approach. That would be the answer. And to do that, we have to make things convenient and easy, because as you all know, these research visits are not easy. So,
I was just going to say, we're doing some work along that. I'd be happy to talk to you afterwards in terms of how we're reaching not only African Americans, but also diverse populations with regard to citizens and minorities and folks who are I'm from North Carolina, so I'm talking about rural North Carolina, places where people are hardest to reach, not to reach.
So that's Dr. Byrd talking about her outreach to rural communities. She's been doing this. She's a huge fan. But you get out of the university, out to the outlying areas and people who wouldn't normally come to a university clinic. Yeah.
They don't want to come to.
Exactly. We get lost when we come there. It's uncomfortable. Again, that culture of a university, we are a culture. Yeah. It's uncomfortable.
Good. Yeah, in the back there. Would you introduce yourself? Yeah.
My name is Oliver. I'm coming from NYU as well. And same thing as Peyton, looking at the association for slow wave sleep and amyloid burden. And I just wanted to ask about the discrepancy in the referrals.
Yeah.
A healthcare professional and a friend. That was interesting. How that referral from a healthcare professional increased the risk.
Isn't that something? Yeah.
Was the demographics of those healthcare professionals taken into account?
Oh, that's a great question. So Oliver from NYU asked about the demographics of the healthcare professionals who are making referrals, and whether or not there is a consideration of the demographics of those healthcare professionals. Well, Oliver, I suspect we know what they are, right? Okay. They're university clinics that are they're people who are getting there are highly resourced and connected to these resources. And then the healthcare professional, oftentimes, there's a bias in terms of who we refer to. I've heard these conversations in clinic, saying, well, they're not likely to participate, so I'm not even going to bring it up with them. I do think right there from the get-go, what are we doing to our science when we are only referring a subset of individuals? I don't have the answer to your question, Oliver, but just some editorial thoughts.
Yeah, we'll take both questions. We're filling a little time while they're setting up the break, so I'm glad there's a lot of questions. Yeah.
This is like kind of more of a comment than a question, but so in my study in autism, I'm Destiny, by the way, from ASU. In my study in autism, we kind of see, so we're following people as they age as well, like different comorbidities with autism and stuff. So I kind of saw that same thing that you were talking about, how it's like similar at baseline, and the conclusion that we kind of came up with was like cohort effects and compensatory strategies.
Let's talk a little louder. It's hard to hear you.
Sorry.
Yeah.
Cohort effects and like compensatory strategies that people use to kind of, I guess, diminish the impacts of different sort of things that could happen to them.
Yeah.
I'm wondering if you kind of thought about that as well.
That's interesting. So if I understand correctly, what Destiny from Arizona was looking at in her autism study was that there are cohort effects, and the cohort effects reflect own personal strategies and sort of approach to the tasks in life, maybe even. I haven't looked at that. That's really interesting. I do think your access to things, maybe reflects, I'm sure, some of your resourcefulness, maybe, or approaches. In some regards, yeah. But I haven't thought of that. But thank you.
Thank you very much. We have to move on.